Hello, my name is Scott Burns, and I have the pleasure of being able to present some of my recent research regarding hip impairments for those individuals with low back pain. We'll first talk about a number of different things, but initially I would like to thank the Duke Center for Excellence in Manual and Manipulative Therapy for the invitation to present and record this information for their center. But let's get into it. So the objectives of what I'm going to try to accomplish in this short video is to really describe some of the conflicting literature about the role of the hip impairment, which is one of the reasons why I undertook some of this research. And then we'll describe the study in general, and then we'll talk about the outcomes at short term and long term with that RCT. And then we'll discuss how these can actually be used in clinical practice. So initially, with some of the background, this was termed hip spine syndrome, which was coined in 1983. So it's been around for quite a while. It's gathered more recent attention probably in the last 10 to 15 years with a surgical study in 2007 where folks underwent total hip and they had concurrent back pain, and they also got better with that. So that garnered some attention from the surgical medical community, and then it kind of has bled over into some of our physical therapy as well. So the hip impairments are a challenge, though, because it seems like they're, whether we have impairments in range of motion, strength, motor control, they're commonly seen with individuals with low back pain. But there's been, and without low back pain, actually, so symptomatic and asymptomatic folks. And there's been a relatively, not really a strong correlation or pattern for which ones would be most appropriate. So range of motion, there's nothing really consistent about a certain range or a certain direction that seems to be the problem. Same thing with strength. Probably the biggest one there is weak hip abductors. And the motor control might be present, but that's challenging sometimes to understand. So, these motor control, range of motion, strengthening exercises, when we manage this in these types of patients, there's some within group differences for individuals with chronic low back pain, but really it's small. And when you look at it between groups as a general gist of the literature, when you look between groups, there's really no difference whether they received one of these interventions against another one. So range of motion exercises versus strengthening or combinations. But it does seem that some intervention directed at the hips is more beneficial than nothing. So we still have some work to do here, but multimodal management, that includes manual therapy, which might be more pertinent to this group, it definitely has kind of the same thing. There was improvement in pain and disability with physical therapy activities that had manual therapy directed at the hip. So it was not a single study where you just did manual therapy and saw what the result was, but really what you were doing is a multimodal thing with exercises and things like that. But it kind of still conflicts quite a bit. So there seems to be improvement in pain and disability whether or not there is a hip impairment. So that would be someone with low back pain, no hip impairments on examination. They seem to get better if you target the hips. Same thing with if they have a hip impairment. So we're not really sure. So the aim of this RCT that we conducted, it was a parallel group multi-site. I think we had 7 sites across the United States. And it had a long-term survey that was done by electronic survey. We recruited 76 subjects total, and there's 7 clinics between July 2018 to October 2019. And the eligibility criteria is up there, and we'll talk a little bit more about this, but they had to be adults. They had to have at least 2 out of 10 low back pain as their primary complaint, an oswestry that showed at least moderate disability greater than 20%, and they had to have a concurrent hip impairment, which was pretty wide-ranging. Groin pain, low back pain that was reproduced with it, or any range of motion or strength deficit identified by the PT, or a positive Faber or Fader. So lots of ways to get enrolled into that study. The participants were randomized into one of 2 groups, low back only or low back plus hip. And our primary outcomes we were looking for was pain, so we used the NPRS, and disability, which was measured by the ODI. Secondarily, we looked at a number of things, but the two main ones were fear avoidance beliefs and the global rate of change. And we did repeated measures at multiple time points from baseline, 2 weeks, discharge from physical therapy, and then 6 and 12 months post-discharge from physical therapy. So the interventions that we did, low back only, the design of this was pragmatic in nature, so we wanted to resemble clinical practice to the best of our abilities. So the pragmatic nature is the physical therapist was allowed to treat the low back only in this group. They couldn't treat anything for the glutes, they couldn't treat anything down at the hip joints, just whatever they would do for the low back. Then the low back plus hip group got the same pragmatic treatment for the back, so the therapist could do whatever they wanted to do. And then they also had to choose, based on their evaluation, what at least 2 manual therapy techniques and 2 exercises that were geared towards those impairments that they found. So it's a semi-pragmatic approach for the low back plus hip group. And the results were kind of like what I described earlier, is within the group, both groups got better. You can see here that the blue line is the low back only and the orange line is the low back plus hip. And you can see that, for Oswestry, which is on the top, they both consistently went down, starting from an average of around 30, and they got down towards like a 10. Numeric pain rating started a little above 4, ended up a little bit between 1 and 2. So they all did pretty well, and they maintained it over time, which was nice to see. It shows that what we did, whether it was targeting the low back or the low back and the hip, seemed to do something. Unfortunately, there was no between group differences for NPRS or Oswestry. The only one that had a between group difference was the fear avoidance belief questionnaire, particularly the work subscale, at 2 weeks, and that favored the low back only group. So they had a greater reduction in fear avoidant beliefs at 2 weeks compared to the low back plus hip. It's hard to make sense of why that might be, but it seems like they had less fear at 2 weeks, and maybe that was partially why you see some of their pain and their disability a little bit lower. There are a lot of limitations. They're listed in the paper, but inclusion criteria was pretty wide, meaning we took a lot of different types of folks. The duration was pretty long. There's contamination bias, where somebody could have done hip treatment for somebody in the low back group. And then the long terms, unfortunately, the long-term follow-up for a lot of the folks was during COVID. So there's a pretty high dropout rate. So take the 6 and 12 months, I kind of need to have like a little asterisk next to it during the COVID times. So from a relevance standpoint, adding semi-pragmatic hip interventions, manual therapy, and exercise, while it didn't change pain and disability more so than just treating the lower back, I think this does give you, as a clinician, that if they come in, the low back is really irritable, treating the hips is a viable option, and it shouldn't be discarded. So you can definitely treat the hips early and often, particularly if we think that there's some involvement where they have comorbid conditions in there. Maybe that would be appropriate. Unfortunately, we don't have a clear direction as to when you should treat the hips or when you shouldn't, so it's still left to some of our decision making. You can access that full the study right there with that link or the QR code at the very beginning. So I hope this was beneficial, and thank you so much for listening.